Hello, everyone. It's my great pleasure to introduce Dr. Alton Russell. Dr. Alton Russell is a postdoc fellow at Harvard at Harvard Medical School and the Massachusetts General Hospital Institute for Technology Assessment. His research is focused on the development of decision analytical models to inform health policy and clinical practice, integrating methods from simulation, operations research, data science, and health economics. He will be joining the School of Population and Global Health at McGill in January 2022 as an assistant professor. So let's welcome and let's give the floor to Dr. Alton Russell.
Thank you, Yishuan, and thank you to everyone for inviting me. And I'm excited to speak with you. So the slides say Stanford because this talk is mostly derived from my Stanford dissertation, which I defended in January. But as Yishuan said, I'm currently a postdoc at Harvard Medical School. And then next January, I'll be joining the faculty in the School of Population and Global Health at McGill. So my research focuses on using decision analytic models to evaluate and inform health policy and clinical decisions. And today I'll be focused on using models to inform the safe collection and transfusion of donated blood. And as a disclosure, I've received consulting fees from Terumo BCT in conjunction with the first project I'm going to present today. So in the 1980s, epidemics of HIV and hepatitis C through blood transfusion created public health crises in health systems around the world. And in Canada, more than 2,000 transfusion recipients were infected by HIV in the 1980s, and over 30,000 were infected by hepatitis C. So at least before the COVID-19 pandemic, this was widely considered the largest preventable public health disaster in Canada's history. And I guess we'll see if that remains to be the case. And the Canadian Red Cross made several blunders, such as using a faulty test to reduce risk of HIV, failing to implement serological hepatitis C screening until 1990, which is 4 years after the United States did, and failing to reach out to individuals who were exposed to infectious blood products, which allowed them to spread in the community through sexual transmission of HIV and hepatitis C. So after a judicial inquiry led by Justice Horace Creever, the Red Cross was barred from blood collection in Canada, and two new blood agencies were created, Canadian Blood Services and HEMA Quebec. And so since this major scandal in Canada, as well as similar scandals throughout the world, safeguarding the donated blood supply has been a critical public health priority. And there are three classes of interventions that can avert transfusion-transmitted infections. So donors who have specific risk factors can be deferred from donating either temporarily or permanently. Donors can also be tested for disease. And then risk-reducing modifications like pathogen reduction or leukoreduction can be used. And these basically are treatments that are applied to the blood unit that make it less likely to transmit disease to the recipients should it contain a pathogen. So today I'll present three products from my dissertation, and I'm presenting them in increasing order of methodological innovation. So the first project uses pretty standard cost-effectiveness methods. The second introduces a new microsimulation model to more accurately capture the health economic consequences of transfusion-transmitted infections. And then the third project will introduce a new optimization framework that extends cost-effectiveness analysis to consider all feasible combinations of blood safety interventions, rather than just a small subset. And these projects will all focus on different settings and different blood safety threats. So the first is a cost-effective analysis of pathogen reduction technology in Ghana. The second assesses the United States' decision to screen all blood donations for Zika virus. And in the third, I'll illustrate the framework I developed using a case study focused on portfolios of interventions to prevent two mosquito-transmitted diseases in the blood supply in the United States. And so starting with the cost-effectiveness of whole blood pathogen reduction in Ghana. So pathogen reduction uses riboflavin and UV light to reduce pathogens in blood products before they're transfused. And while prior studies have analyzed platelet and plasma pathogen reduction in high-income countries, there's no health economic assessment available for whole blood pathogen reduction. And whole blood pathogen reduction is important for countries like Ghana, where blood is most often transfused as a single whole blood unit, unlike in other countries like Canada and the United States, where it's typically fractionated into different components that are transfused separately. And in Ghana, donations are routinely screened for HIV 1 and 2, hepatitis C, HIV surface antigens, and syphilis. And a recent study in Ghana estimated that whole blood pathogen reduction would lead to a 6-fold reduction in the rate of transfusion-transmitted malaria. So our analysis focused on the impact of whole blood pathogen reduction in reducing risk for 7 adverse events. Those are HIV, hepatitis B and C, a transfusion-transmitted bacterial infection that leads to sepsis, malaria, syphilis, and febrile non-hemolytic transfusion reactions, which is it's a non-infectious adverse event. And for each adverse event, we estimated the incidence and its burden in terms of the disability-adjusted life years lost. So disability-adjusted life years are, it's a measure that takes into account both mortality as well as morbidity. And we considered direct healthcare costs with and without whole blood pathogen reduction. And we then estimated the budget impact and cost effectiveness of whole blood pathogen reduction and performed extensive uncertainty analysis. So we parameterized a risk reduction model based on published literature and local data to estimate annual incidence of adverse events with and without whole blood pathogen reduction. And we modeled a separate adult and pediatric cohort. And our model accounted for the annual number of blood units transfused and the % of collection units that are not transfused. And for each adverse event, we estimated the baseline risk without whole blood pathogen reduction, the probability that transfusing a unit containing a pathogen leads to symptomatic outcomes in the recipient, as well, and this taking into account things like the rate of vaccination against hepatitis B, for instance, and as well as the fold risk reduction of whole blood pathogen reduction. And for each parameter, we assigned an uncertainty range and a distribution for sensitivity analysis. And I'll point out here that you'll notice that for the baseline risk, it's much higher for transfusion-transmitted bacterial infections than the other adverse events at 15%. So we estimated the burden of adverse events in terms of the direct healthcare costs and the disability-adjusted life years. And our model accounted for the timing and likelihood that adverse events are detected and the clinical treatment that's provided typically in Ghana. And we discounted future costs and disability-adjusted life years at 3% annually. And our model factored in a 6 to 9% inpatient mortality risk, after which we assumed normal life expectancies using Ghanaian life tables. For medical costs, we use a detailed microcosting approach to estimate the clinical resources utilized and their cost. And we developed these estimates through a series of conversations with my clinical collaborators in Ghana. We also estimated disability-adjusted life years using the Global Burden of Disease study and other studies that include disability weight estimates. And for the chronic diseases, so that's HIV, hepatitis B, and hepatitis C, we developed Markov models that capture the disease natural history, the timing of detection and treatment, as well as treatment success. And the natural history models and treatment efficacy are based on published literature, while the timing and detection of treatment is mostly based on my clinical collaborators' expertise. And just to illustrate one of the 3 chronic disease models, I'll briefly go under the hood for the HIV model. So I'm showing 2 plots, each of which has the age of the simulated pediatric and adult cohorts on the x-axis. And on the left is a calibration plot for the natural history parameters, which are based on targets derived from a longitudinal study of HIV outcomes from before antiviral treatments became available in Uganda in this case. And the top plot shows the % of each cohort who have progressed from HIV to AIDS. And the bottom plot shows the % who are still alive. So the calibration targets from the literature are shown as a point and bar, and the dashed lines show the lower and upper bound estimates using our calibrated parameters. And you can see that we have pretty good fit to the data. And then the Markov trace plot on the right shows the % of each cohort that is in each disease state over time. And the top is the adult cohort and the bottom is the pediatric. And for both cohorts, nearly all infected transfusion recipients begin with subclinical HIV, shown in red, and most are diagnosed and begin antiviral therapy, shown in green, before they progress to AIDS. And while some die of HIV or AIDS-related complications, shown in blue, most most who, because they receive treatment, die from other causes, shown in purple. And so this table shows our estimates for the burden of each adverse event without whole blood pathogen reduction. So HIV, hepatitis B and C are the chronic viral infections that have, and they have the highest net present cost per case. However, their annual incidence is relatively low, in large part because we're testing for all of these. So, and on an annual basis, they represent about 7% of cases and 21% of costs, and only 6% of disability adjusted life years incurred without whole blood pathogen reduction. On the other hand, sepsis, it has the highest per cost disability adjusted life year burden and a fairly high net present cost. And it represents about 40% of all cases, 70% of all costs, and 90% of all disability adjusted life years incurred due to adverse events without whole blood pathogen reduction. So these slides show the estimated impact of whole blood pathogen reduction. And we estimate that whole blood pathogen reduction would avert 12 to 27,000 adverse events a year, of which 30 to 70% are bacterial sepsis and 13 to 40% are malaria. We estimate whole blood pathogen reduction would reduce about $5 to $14 million in direct healthcare cost, of which 50 to 90% are due to averted bacterial sepsis cases. And whole blood pathogen reduction would cost between $6 and $10 million a year. And we estimate that it would have a net savings of about $600,000 a year, but this has an uncertainty range that ranges from a net cost of $3.7 million to a net savings of $5.4 million. And this figure shows the sensitivity of the net savings of whole blood pathogen reduction to the uncertainty in our individual inputs. So the x-axis is the net savings of whole blood pathogen reduction, which was about $600,000 in our base case. And on the y-axis are our input parameters with their uncertainty ranges. And the width of these bars indicates the range of our outcome, the range of values that our outcome might take when varying the input parameter along the range that's been assigned to it. So for the probability that a bacterially contaminated blood donation leads to sepsis when it's transfused, we have a very wide uncertainty range from 5% to 70%, because this is a parameter that's not well characterized. And we can see that there's tremendous uncertainty in our outcome based on this. The conclusion that whole blood pathogen reduction would be net savings was also sensitive to the cost of whole blood pathogen reduction and 4 other parameters. So this scatter plot shows our cost effectiveness results. So the incremental disability adjusted life years averted are on the x-axis and the net incremental healthcare cost on the y. And about 58% of iterations, that iteration fell below this line, meaning that whole blood pathogen reduction was cost saving. It saved more money than it cost. And in all iterations, it never cost more than $700 per disability adjusted life year, which is well below the per capita gross national income in Ghana, which was $2,200 in 2019. So this is a relatively affordable intervention. And here I'm showing the cost and disability adjusted life year scatter plots for 2 scenario analysis. So the panel plot, the top panel shows a scenario where we accounted for 1 secondary infection per infected recipient with HIV or hepatitis B or C. And in this scenario, the percent of iterations for which whole blood pathogen reduction was cost saving increased from 58% of iterations to 82% of iterations. And the bottom panel is a scenario where we excluded bacterial infections leading to sepsis. So recall that sepsis accounted for most of the health economic benefit in our base case. So we ran this scenario where we excluded sepsis benefits because Ghana has higher transfusion-transmitted bacterial contamination rates than other African countries. And in other countries use other interventions to prevent bacterial sepsis contamination. So this scenario might be more informative to other countries with less contamination, and could also be considered a lower bound of sorts on what the benefits of whole blood pathogen reduction would be if Ghana implemented other measures to reduce bacterial contamination. So in this scenario, whole blood pathogen reduction is no longer cost saving, but it costs less than the WHO recommended threshold of 3 times their per capita gross national income per disability adjusted life year in 99% of iterations. So in this project, we estimated that whole blood pathogen reduction is very cost effective and possibly cost saving in Ghana when factoring in direct healthcare costs. Whole blood pathogen reduction might have other benefits that we didn't capture, such as preventing sexual transmission of infectious diseases, preventing other adverse events, which may include future emerging infectious agents, and reducing non-medical costs, such as productivity loss when ill or family caregiver times. So due to these uncaptured benefits, the societal benefit of whole blood pathogen reduction likely exceeds the direct healthcare benefits we estimated here. Our analysis also suggests that bacterial sepsis is an underappreciated blood safety threat in sub-Saharan Africa. The main limitation is lack of recent data on many model parameters and updated estimates of the risk of adverse events in Ghana and better data on clinical outcomes, particularly with respect to transfusion-transmitted sepsis would reduce uncertainty. I'll also say that the modeling methods and analysis were not particularly novel, but we did improve on prior blood safety analyses because we explicitly modeled the timing and likelihood that diseases are detected and treatment is provided based on local clinical practice. So this led to lower estimates in terms of the cost of adverse events because we didn't assume everyone would receive treatment necessarily. So like clinicians everywhere, my collaborators in Ghana weren't experts in decision analytic modeling or health technology assessment. So this is my first time trying to collaborate with people in another country over Zoom, essentially, to elicit these parameters. And it actually went quite well. So I definitely would recommend anyone who's modeling a decision problem in another country or a lower middle income setting to seek out collaborators who can help provide parameter estimates and inform assumptions. One caveat, of course, is that parameters estimated in this fashion should have conservative uncertainty ranges around them. So that's the first project. I'm happy to pause here if there are any questions. All right, well, hearing none, I will move on to the next project, which is a cost-effective analysis of screening for Zika in the United States. So at the time of this analysis, Zika virus was considered an emerging blood safety threat, and Zika can be transmitted through blood donation, and most people who are infected have no symptoms. Most symptomatic infections involve a mild febrile illness, but in rare cases, Zika has been associated with Guillain-Barré syndrome, which can lead to permanent paralysis, as well as congenital Zika syndrome, which is associated with devastating birth defects. And the United States began testing all blood donations for Zika in Puerto Rico first, and then rolled out universal testing of all blood donations by the end of 2016. And during that time, 2 areas in the southern United States were considered by the CDC as having risk of local mosquito transmission of Zika. So it's just around Miami and then Brownville, Texas. So in this project, we assessed whether it was cost effective to spend over $120 million a year to screen all the blood donations for Zika virus. And we also evaluated the screening policy against more targeted alternatives. So the simulation that I developed simulates transfusion recipients under each policy for 1 year and estimates the number of cases and transfusion recipients, their sexual partners, as well as newborns. We also estimates the cost of blood centers for the screening program, as well as the lifetime costs due to the transfusion-transmitted Zika from a societal perspective. So this is taking into account like productivity loss while ill or due to death. And we estimate the incremental cost effectiveness ratios in dollars spent per quality adjusted life year gained. And we modeled Puerto Rico and the United States separately. Just a brief note, since the prior analysis, I used disability adjusted life years, which is the most common measure of health utility for global health studies or studies in low and middle income country. Whereas in like United States, Canada, and Europe, analyses typically use quality adjusted life years. There are some differences between the two. However, for the purpose of this talk, I mean, you can think of them, they're quite similar. They're both basically assign a utility of 1 if you're in perfect health, or sorry, well, quality adjusted life years assign a utility of 1 if you're in perfect health, 0 if you're dead, and then a number between 0 and 1 if you're ill, depending on the severity of your illness. And disability adjusted life years are essentially kind of the same thing, but in reverse. So I'll briefly describe 3 unique methods for this analysis. So prior blood safety models had to use decision trees and Markov models that simulate outcomes in the average transfusion recipient. And I instead developed a microsimulation that captures the relationship between the number and type of blood components transfused and the recipient's outcome. And this can be important because the number and type of blood components a recipient receives often depends on their patient's condition. And patients who receive a lot of units might have different baseline characteristics, such as age or expected survival, that can matter in terms of estimating the health economic consequences of infecting them. Secondly, because serious adverse events from Zika are very rare, I developed a conditional Monte Carlo approach for the simulation where I simulate each recipient with and without transfusion transmitted Zika and estimate their outcomes. And then I weight these outcomes by the probability that they would receive Zika based on the number and type of blood components that they receive. And then finally, I performed linear regression meta-modeling for univariate sensitivity analysis. So in probabilistic sensitivity analysis, that's basically what generates that scatter plot I showed for the last project, where you have thousands of different realizations of the input parameters mapped to the outcomes. Basically, you can use these data to train a linear regression model that you can use to estimate how varying the input parameter will vary your outcomes. In this case, the costs and quality adjusted life years incurred. So to enable targeted assessment of targeted screening policies, I analyzed the data from the first year of testing in the United States and Puerto Rico, or the 50 states and Puerto Rico rather, and estimated the rate of Zika contamination in blood donors across different groups. So for the 50 states, I estimated risk separately for donations collected during the local outbreak in Texas and Florida, and then in donations from individuals with potential travel exposure, and the rate in individuals with no known exposure risk. And then for Puerto Rico, I estimated the risk differently in the low mosquito season and the high mosquito season, since Zika is primarily mosquito transmitted. And as you'll see, there's considerable variation across in risk across these groups. So donations from Puerto Rico in the high mosquito season, there's about 6 in 1,000 rate of Zika contamination, whereas in donations from the 50 states with donors with no known exposure risk, it's less than 1 in 10 million donations that are contaminated. So in both settings, I simulated a no screening policy and then 2 versions of a universal screening policy, one with individual donation screening and one with mini pooled testing. So in mini pooled testing, basically you sample from 6 to 16 different donations and you run the assay on that pooled sample. And then if the pooled sample tests positive, you then go back and test each donation individually. And doing it this way can reduce the per donation cost, but also reduces test sensitivity. In the 50 states, I considered only testing during a local outbreak, which I call location adaptive testing, as well as testing both during a local outbreak and for any travelers who've returned from a location experiencing a local outbreak within 3 months, which I call travel adaptive testing. And I evaluated both an individual donation and mini pooled version of each of these. And then in Puerto Rico, I considered 2 versions of testing exclusively during the high mosquito season, one with the individual donation test and one with the mini pooled test. And then I also considered mini pooled testing during the low mosquito season and then escalating to individual donation testing during the high mosquito season. And then not shown in these figures, I also considered 2 separate inventory policies. So in these, you screen just a fraction of the blood supply that is designated to be transfused to women of childbearing age as a way to try and avert the risk of congenital Zika syndrome. Before showing results, I'll briefly introduce incremental analysis, which is a standard method for evaluating cost effectiveness. So this requires first defining a threshold of how much you're willing to pay for health per unit of health benefit. And in the United States and in Canada, thresholds between $50,000 and $150,000 per quality adjusted life year are typical. However, we use a much higher threshold of $1 million per quality adjusted life year. And this is because in blood banking, policies are routinely adopted that have cost effectiveness profiles around $1 million per quality adjusted life year, which I think is a reflection of just the risk aversion that policymakers have based on the history and based on the fear of another crisis in confidence in the blood supply. So once you define your willingness to pay threshold, you then order your interventions by increasing effectiveness, and then you can remove dominated interventions. And A dominated intervention is an intervention like option 1 here. So if you look at option 1 compared to option 2, it's more expensive and less effective. So there's no reason why you would ever want to prefer more expensive, less effective intervention. So once you've removed dominated interventions, you look at the interventions that are remaining, which are called on the efficiency frontier, and you calculate the cost effectiveness ratio, which is essentially the slope of the line. So it's the difference in cost over the difference in quality adjusted life years. And then you essentially just, the intervention that's preferred is the intervention that has the highest incremental cost effectiveness ratio that's still below your willingness to pay threshold. So in this case, option 3 cost a little bit over $1 million per quality, which is our threshold. So we would say option 2 is the preferred intervention. So now on to the results. So here I'm showing the efficiency frontier plots for Puerto Rico and the United States. First looking at Puerto Rico. So screening with mini pool testing in the high mosquito season costs only $81,000 per quality adjusted life year, which is below willingness to pay threshold. And then escalation to individual donation testing in the high mosquito season costs $1.2 million. So it's over our threshold. So this is the preferred policy. And I should also note that the separate inventory policies were always dominated. And that's because a lot of the health consequences from transfusion-transmitted Zika come actually from the mild febrile illness, just because the rare congenital Zika syndrome is just so rare. And then in the 50 United States, it looked quite different. So even the most targeted, least expensive strategy of location adaptive mini pool testing still cost almost $10 million, or almost 10 times our willingness to pay threshold. So in the 50 states, no screening policy for Zika is cost effective. And then looking at our sensitivity analysis, the finding in the 50 states was quite robust. So in all but one of our 10,000 probabilistic sensitivity analysis iterations, no screening was the preferred intervention. In Puerto Rico, there was more uncertainty. So mini pool testing in the high mosquito season was preferred in 64% of iterations, but using the more sensitive individual donation testing was preferred in about 20%. And the preferred policy was sensitive to 5 input parameters. So this is from our linear regression meta modeling. So when varying these 5 parameters, plus or minus 2 standard deviations from the base case value, we found that escalation to mini pool to individual donation testing was warranted. Like if the sensitivity of the mini pool test is lower, the cost of the mini pool test is higher, the cost of the individual donation test is lower, or if the duration for which people are sick with febrile illness from Zika or the probability of congenital Zika syndrome are higher. And you can see for these 2 parameters, if the value is high enough, we actually want to switch to the policy of mini pool testing in the low mosquito season, and then individual donation testing in the high mosquito season. And so recall that I developed this microsimulation structure in order to try and capture the differences between those who are at high risk of transfusion-transmitted Zika and other donors. And we found that this can matter. So in the simulation, the recipients who experienced transfusion-transmitted Zika tended to receive more units, and a higher proportion of the units they received were plasma. And they also tended to actually be younger on average. But even though those experiencing transfusion transmission were younger, they actually were sicker and had a lower life expectancy. And so this relationship could be even more important for chronic diseases like HIV or diseases with a higher mortality, just because this difference in life expectancy might actually factor into the health economics more substantially than for Zika. So I'll give kind of what happened after we published. So, well, actually, before we published, the FDA allowed transitioning from individual donation testing to mini pool testing. And then this paper came out in January of 2019. And then in April of 2019, the Blood Products Advisory Committee met to discuss whether they should continue screening for Zika, and they did discuss our paper. We submitted a letter to the committee. However, members of the committee said things like, no risk model. We don't really have a risk model for serious adverse events. We don't really know what's going to happen. And I think this is a little bit of a misunderstanding with our paper, because while they acknowledged that our analysis was a cost effectiveness analysis, it also did include a risk analysis. You have to build in a risk analysis in order to do the cost effectiveness analysis. And so we did have a model to estimate the risk of serious adverse events. But anyway, at that meeting, they thought they'd continue screening for just one more year and revisit it in the spring of 2020. And that was on the docket, but in March of 2020, that meeting was canceled and has not been rescheduled. So the Blood Products Advisory Committee has not met since 2019. And screening has continued this whole time. And because of this, I decided to publish a brief follow-up. I was actually preparing this analysis for the advisory committee meeting, but since it was canceled, I published it instead. So this was a brief report in Annals of Internal Medicine, where basically we're spending around $10 million a month on screening for Zika. The yield has been quite low. So we only found 3 units in 2018, and we haven't found any Zika positive blood donations since. And I also wanted to make the point that we do have a risk model, and the risk of serious adverse events is quite low. So here I'm showing the risk in terms of the average year between expected number of years between each case for the 2 serious adverse events as a function of the rate of Zika in the blood supply. So at the rate we saw in 2018, at our kind of high risk 99% credible interval of risk, the risk would be about over 1 in 1,000 and for both diseases. So basically, risk is quite low. However, since 2019, there have been 0 confirmed Zika cases in the United States and its territories. However, the FDA has not revised the requirement to screen all blood donations because they haven't revisited it since then. So I can pause again here if there are any questions before I go on to the last project.
So you think about the quality, that's the single objective, and then the cost, right?
Mm-hmm. I mean, for the cost effectiveness analysis, that's what's factored in. But we also report other outcomes like the expected number of cases. So those are the two measures that go into the cost effectiveness. But we also report other outcomes.
Like what? Sorry, like what?
Like the estimated residual risk. So the expected, that was kind of the point of this brief follow-up was because I think that, in the abstract of the paper, like most cost effectiveness analyses, we focus more on the cost effectiveness results, which led people to think that, we don't have a model to estimate, like a risk estimation model. But, I did report in the original paper, the expected number of, of each of the adverse events under each policy with an uncertainty estimate. However, since this was kind of largely lost, and it was clear from the Blood Products Advisory Committee meeting that, they were very interested in those results and they'd missed them in the original report, which is why I developed this follow-up to that focused, instead of focusing on the cost effectiveness, it focused more on those risk estimates and took a very conservative approach, right? So only reporting like the 99th percentile estimate in terms of the risk, and even taking this very conservative approach, the risk of these adverse events are quite low.
Okay. And so if you do quality, do you discount the future? For example, if you can save 1% now and save 1% in the future, is there a difference?
Yes, we do. So you both cost and the quality asset life years, and then in the earlier analysis, the disability asset life years are discounted at 3% annually. However, there's recently been some work suggesting that maybe a lower discount rate is more appropriate, but in our case, it doesn't make a huge difference because most of the burden of the disease occur in the first year after transfusion.
Okay, thank you.
All right, well, if there aren't any other questions, I'll move on to the third project, which focuses on evaluating portfolios of blood safety interventions. And traditional cost effectiveness analyses, like the 2 I presented today, they can compare a handful of interventions, but they can't consider all possible combinations because they're too numerous. And just consider a small example where you have 5 donor groups you might defer, 4 tests you may or may not use, and then 1 modification like pathogen reduction. And if you're willing to use a different set of tests and modifications in each donor group, you have nearly 40 million different portfolios, possible portfolios or combinations that you could consider. But if you restrict yourself to only to saying like, okay, I'm going to decide which donor groups I'm going to defer, and then I'll use the same set of tests and modifications for each of the non-deferred donor groups, that does considerably reduce the state space, but you still have over 1,000 portfolios, which is too large a number to assess with traditional cost effectiveness analysis. And a series of papers over the last 10 years developed some nice methods to optimize test selection. However, these methods don't consider donor deferral or modification interventions, and they're not consistent with cost effectiveness analysis. So this project had two objectives. First, to develop a framework to determine the optimal portfolio of defer, test, and modify interventions in a manner that's consistent with cost effectiveness analysis. And second, to apply this framework to retrospectively evaluate the United States policy for Zika and West Nile virus, which are both mosquito-transmitted infections. And in cost effectiveness analysis, the optimal policy is that which maximizes the net monetary benefit. And in our model, we use the net present net monetary cost of releasing an infectious donation into the blood supply. We indicate that with the variable C. And this net monetary cost is essentially the opposite of net monetary benefit. And this is how we ensure that our optimization problem remains consistent with cost effectiveness analysis. So I'll first present a simple case where we have to decide whether to accept or defer a single donor who might have a single disease. And the decision variable Z will equal to 1 if we accept a donation and 0 if we reject the donor. Rejecting incurs a replacement cost D, and accepting incurs a processing cost W. And then there's some probability P that the donor will be infectious. And if they are, we will incur the expected net monetary cost of releasing that infectious donation into the blood supply, which we represent with C. And so in this simple problem, we should reject the donation if the disease risk exceeds the difference between the replacement and processing cost divided by the net monetary cost of releasing an infectious donation. And if this solution seems familiar, that's probably because it ends up being the same as the classical news vendor problem. So in the full model, we have multiple donor groups and multiple diseases, and we have to decide which donor groups to accept. And we have parameters related to the number of people in each donor group, as well as the risk of each disease in each donor group. We also have to decide which test to apply in each donor group, and each test has a per donation cost and a sensitivity and specificity for one or for more diseases. So there are some multiplex tests that test for multiple diseases. And finally, we have to decide which modifications to use in each donor group. And each modification has a per donation cost and a risk reducing multiplier for each disease. And here's the full cost function we developed. So the first term captures costs for donor groups who are deferred, and we incur a per donation replacement cost for them. The second term captures costs for any donor groups we accept, and those include costs for processing their donation, any tests or modifications that are used, and the cost of releasing infectious donations into the blood supply. And then this last term captures the cost of removing and replacing any donation that tests positive. So if a donation tests positive, we have to perform confirmatory testing. We have to notify the donor and defer them. And we also need to replace that donation. And then by adding constraints to this objective function, we can write two versions of the optimal portfolio problem. So if health systems are willing to tailor the set of tests and modifications to each donor group's risk, then we have just one constraint. And then if they prefer to use the same set of tests and modifications in all accepted donor groups, we add two more to enforce that restriction. So the portfolio problem can be solved by exhaustive search, but this requires too much compute time for larger problems. So I'll briefly mention 4 methods I developed to solve the problem more efficiently. So first, I showed that for the tailored portfolio problem, we can solve it more efficiently by solving each donor group separately. Next, I developed tests that can be, or checks that can be applied to remove interventions from consideration before running the full model. And then each intervention you remove before running the model approximately halves the policies that need to be considered. Third, when the number of donor groups is large relative to the number of policies, then it might be more efficient to learn a function mapping prevalence to optimal policy, and I'll show that for the case study. And then finally, I developed and assessed a linear approximation of the full objective function that makes the problem amenable to a class of solution techniques developed for integer programming problems with linear objective functions. So regarding the case study, I considered West Nile virus and Zika, which are both primarily transmitted by mosquitoes. And the prevalence can vary considerably by geographic area, by season, and it can look quite different from one year to the next. And for both diseases, we have multiple tests available and modifications, and we can also defer donors who are high risk. So I looked retrospectively to determine what the optimal policy would have been for Zika and West Nile virus for the United States for the year 2017 to 2019, where donor groups are defined based on both the high and low mosquito season, as well as by 3-digit zip code, which is the first 3 digits of a normal 5-digit zip code. And I repurposed the recipient level microsimulation that I developed for the Zika cost-effective analysis to estimate the expected net present net monetary costs that are incurred each time an infectious donation is released for transfusion for each of the 2 diseases. And that net monetary cost was about $10,000 for Zika and about $38,000 for West Nile. And here are parameters related to the modification and testing interventions. So I evaluated pathogen reduction in plasma products. And that's because the whole blood pathogen reduction, which I presented earlier in the analysis for Ghana, is not yet FDA approved. But so because the plasma pathogen reduction is used on just one of the three components derived from a whole blood unit, it only reduces risk by about 1/3. And then for both of the 2 diseases, I considered both the mini pooled and individual donation version of nucleic acid testing. And then prevalence for each year was based on data from the actual testing data for these 3 years of testing the blood supply. And all other parameters were sampled from distributions and ran in 10,000 iterations of probabilistic sensitivity analysis. And so here are some results. So in the model, the optimal portfolio did vary considerably from one year to the next. So in this figure, the zip codes are shaded according to the percent of probabilistic sensitivity analysis iterations for which West Nile virus testing was optimal in the high mosquito season each year. And you can see that the areas for which testing was optimal can look quite different from one year to the next. If you look at North and South Dakota in 2018 compared to 2019, you can see a huge difference. Zika testing was only optimal in Puerto Rico in 2017 in about 20% of iterations, and mainly using mini pool testing during the high mosquito season. And in most iterations, so more than 93% of iterations, Zika testing was not optimal anywhere in the continental United States. And then pathogen reduction and deferral were never part of the optimal portfolio. So to understand the optimal portfolio a little bit better, I compared it to 2 alternatives, which are using no testing or no intervention for Zika or West Nile, and universal mini pool testing, which is approximately what we currently do, although the current policies do have us escalate from mini pool to individual donation testing in certain cases when we detect positive donations. So as expected, our optimal solution minimizes our objective function value. In terms of testing costs are considerably lower than if using universal testing, it's a small fraction. The optimal solution would eliminate over 60% of the West Nile virus risk each year. It eliminates very little to no risk of Zika, but this isn't surprising since the risk of Zika is quite low to begin with, and because Zika testing was almost never part of the optimal portfolio solution. So one of the solution methods I mentioned earlier is learning a function that maps the prevalence of the diseases to the optimal policy. And here I'm showing that for our case study. So in this figure, the prevalence of Zika in the blood donations is on the x-axis, and the prevalence of West Nile virus is shown on the y-axis. And the shaded regions correspond or show what policy is optimal for that combination of Zika and West Nile virus prevalence. So when risk for both diseases is low, then no testing or no intervention is the optimal policy. If risk gets high enough, then the optimal policy would be to defer donors in that risk group. And then for donor groups with intermediate levels of risk, then testing is optimal with different combinations where the sensitivity of the testing combination increases as the risk gets higher. And so here I'm showing 2 versions of that same figure. And the first one is where I use the full cost function. And then the second is where I use the linear approximation method that I described. And so how this linear approximation works is that we basically ignore the cost related to donations that test positive, which is the nonlinear term, and the objective function. So this term is typically low when the prevalence is low. And so what we find is that in this green square, when the risk of each disease is low, these two objective functions lead to the same policy. But if risk of the diseases is sufficiently high, then we do see a difference between the full cost function and the linear approximation. However, all of the donor groups, the zip code and mosquito season-based donor groups that we looked at fall within this area where the cost functions are very, very similar. And in fact, the optimal policy was the same for all of our donor groups, whether the full cost function or the linear approximation was used. And we can look at different performance metrics of the optimal policy as a function of the risk of the two diseases, as a way to kind of go under the hood of the optimization model. So in this first plot, we see that testing costs are 0 when risk is low, because we're not using any test, and then they become 0 again when we are deferring the donor, and they're highest, of course, when we're using the most tests. And then the cost due to donation testing positive, and this is the cost that our linear approximation ignores. And we can see why it matters more when risk is higher, because this cost is 0 or close to 0. It's not 0, but it's close to 0 when the prevalence risks are lower. But then once we get close to that risk level where we flip over to the donor deferral, those costs can become quite high. And we see that costs due to testing donations, and we see that the total net monetary cost is the only metric that is smooth when we plot it in this way. And this is not surprising, because at the border between different optimal policies is by definition the point at which this objective cost of the two lowest cost policies for that point space are equal. And then finally, we see that risk of Zika and West Nile virus are highest when prevalence is just approaching this point at which risk is high enough to trigger a change to a new testing portfolio. So the optimization-based framework I developed can identify blood safety portfolios from a cost-effectiveness perspective. And as the case study shows, the optimal portfolio can vary considerably depending on the time and place of the analysis. This framework does have several limitations. Firstly, adding diseases into the framework is quite work intensive, and some parameters can be difficult to estimate. Secondly, donor risk stratification, it can be difficult, and particularly if diseases are being considered side by side that have quite different risk factors. So while Zika and West Nile virus, the risk is largely depends on geography and season, so they're consistent. However, considering them alongside a disease like hepatitis C, which has behavioral risk factors, can make stratifying donors into risk groups more challenging. And the main limitation for our case study is that it was retrospective. And if we want to inform current or future policies for blood safety, we would need to combine our framework with current and future risk estimates instead of using past risk. And so in summary, I hope these projects have demonstrated how decision analytic modeling can enable efficient and effective blood safety policy. And these projects, they were all developed to inform specific policy questions. And we found that, pathogen inactivation or pathogen reduction is likely cost saving in Ghana, that screening donations for Zika in the United States is not cost effective, even though it continues to happen, and that the optimal portfolio of blood safety interventions can look quite different from one, depending on the time and place of analysis. And they also make some methodological contributions. So our pathogen reduction analysis, it improved on prior models by accounting for the timing and likelihood that the diseases are detected and treated. The microsimulation structure can be used for other transfusion-transmitted infections to account for the component exposure risk of recipients. And then the optimization framework and solution techniques, they could be used to assess blood safety portfolios in a variety of settings. And I'll close with my vision for blood safety policy assessment. So today we have ad hoc cost effectiveness analyses, which consider a few alternatives and which use disease risk estimated from retrospective analysis. And I hope that this work can serve as a foundation for what I call living portfolio models that can capture all of the relevant diseases and interventions that are integrated with sophisticated disease surveillance models and that can be maintained and updated and refined by either the blood collectors or regulators, and so that policymakers can respond to changes in the available interventions or changes in the epidemiologic conditions. And I've identified 4 areas of future work that can enable this vision of living blood safety assessment models. First, just all diseases and interventions need to be added into the framework. And then disease surveillance models need to be developed that can estimate the risk among the blood donor population and integrate that into the framework. And I'm particularly interested in this decision and surveillance models that integrate data from outside the blood supplies, right? So for West Nile virus, it's carried from place to place by birds, and then mosquitoes transmit it from birds to people. And also, as well as transmitting it to large mammals. So there is currently surveillance data being collected in the United States and Canada, both in terms of monitoring mosquito populations, testing of dead birds, as well as case reports from large mammals and humans. So I'm very interested in integrating these different streams of surveillance data into models to inform the blood safety portfolio models. And West Nile is just one example. This can be done for other diseases as well. And then I think I would like to also develop an interactive tool which I can use to allow policymakers to perform scenario analysis and understand how portfolios trade off costs, health risks, and the supply. And then finally, so while I developed this optimization model for consistency with cost effectiveness analysis, there are other policy objectives such as the minimal acceptable risk that may need to be accounted for. And these can be worked into the framework either by modifying the objective function or adding constraints. Although either of these might impact the solution methods I've developed. So to end, I'd like to thank my wonderful collaborators on the 3 products I presented. So these are my Stanford advisor, Margaret Brandeau, Brian Custer and Mike Bush from Vitalant Research Institute, Susan Stramer from the American Red Cross, as well as Shirley Owusu-Ofori, Alex Owusu-Ofori, Eileen Micah, and Betty Norman, who are all clinician researchers at Komfo Anokye Teaching Hospital in Ghana. And I look forward to hearing any questions that you have.